Thank you for the invitation, and we'll share some insights on our journey in lung transplantation from the medical point of view. We already heard some important messages from the surgical point of view. I think this is really important, but also everything that happens after the surgery is important for our patients. So I have no real conflicts of interest related to this talk. So the first human lung transplantation actually occurred in 1963 in Mississippi by Hardy. And I'm not showing this picture for the fact that it was the first transplantation, but actually for the fact that the patient unfortunately did not survive long. He died after 18 days due to kidney failure. And this is important. It highlights that you have to be prepared after transplant surgery for everything that possibly can go wrong, and you have to be staffed and equipped for this. This is also an interesting case. It's actually the first long-term survivor, transplanted in 1968 from Belgium, the country where I work, in a young patient with silicosis. He was treated with azathioprine and prednisolone at that time. And he had a very complicated post-transplant course, which was characterized by recurrent acute rejections and recurrent infections. Finally, the patient was discharged but readmitted because of a progressive obstructive pulmonary function decline. He died due to respiratory failure. And I show this slide because it's so many years after that day. It still highlights the problems we are facing today in our transplant patients. Exactly the same problems we see still after more than 30 years. It's also an interesting case, this patient, because it was actually the first case with documented chronic rejection after lung transplantation. And you can appreciate from the figure that there was a progressively obstructive pulmonary function. And on autopsy, it was evidence of narrowing of the bronchi and bronchioli and lymphocytic infiltration, which are the typical hallmarks that we would later call bronchiolitis obliterans syndrome. Again, something that we're still struggling with so many years after this procedure. Actually, it was only as of the 1980s, with the introduction of cyclosporin A, that the lung transplant programs really took off. And as an example, this is the first heart lung transplant procedure performed worldwide in 1981. And this lady survived for 5 years, which was already at that time quite long. And as already pointed out by Dr. Keshafji, in the late 1980s, lung transplantation really took off with the expertise developed by the Toronto team, which really developed novel surgical techniques and pioneering investigation in transplantation. And now we are at a very high rate of transplantations. I mean, we can appreciate the annual increase, and we see that every year about 4,500 to 5,000 lung transplant procedures are performed worldwide, with overall about 70,000 transplants being performed now. For the pediatric lung transplantations, you can see the same trend, albeit much lower numbers. So on an annual basis, worldwide, there are only performed around 100 lung transplantations in children on an annual basis. Something that is striking to see, on the other hand, is a decrease in heart lung transplant procedures, both for the adults as well as for the children. And this is due to the better medical treatment and surgical treatment we have nowadays for these patients who are mainly suffering from pulmonary hypertension. This is just to give you an idea on the lung transplant numbers in Eurotransplant. Eurotransplant is a collaborative society which exists of 8 countries, and you can see that around 1,200 individual lungs were transplanted in 2023, which is a quite high number. In Europe, in Eurotransplant, there are around 800 patients on the lung transplant waiting list, and annually about 600 lung transplants are performed. Unfortunately, still 10% of patients die on the waiting list while awaiting a lung transplantation. In my center in Leuven in Belgium, the first lung transplantation was performed in 1991, was right single-site lung transplant for emphysema, and the patient managed to survive almost 1.5 years after transplantation. Our program really had a good start, and you can appreciate from the first 4 patients that their survival was quite good, with the second patient still alive more than 33 years after her heart-lung transplantation. Now, point out that the 4th patient also lived for more than 20 years after his transplantation. And this is our experience over the past decade. So you can see that the first 10 years really was about building experience and getting to know how to handle the most common problems. Later, logistical growth and the use of extended criteria donors led to a steep increase in the numbers of transplantations. And nowadays, last year, we performed 75 transplants on average, and we surpassed the threshold or the milestone of 1,500 lung transplantations in our center. So there is a cumulative number of transplant procedures, but also a cumulative number of patients alive, and you can see that currently we are taking care of more than 740 lung transplant recipients in our center. And so our center really is the largest transplant center in Belgium, in which about 2 out of 3 transplantations of all Belgian people are performed. If you compare this to Europe, you can see that we are not the only big center in Europe. There are several larger centers in Europe. The largest one is Vienna, followed by Hanover, and then our center and some centers in Spain, which are also have increased in the last years in numbers. So quite a lot of bigger transplant centers in Europe. Over the course of these more than 30 years and all these milestones, you can see that there were several firsts in our center. First pediatric transplantation, first redo transplantation, and this is typical what you get in an evolving program, that you are pushing the boundaries, and so having new milestones. But I must say, even with experience of taking care of more than 1,000 lung transplant patients, I can say that every successful transplantation is still a new milestone that we like to celebrate. Just an overview of our transplant patients. So you see that the majority is bilateral lung transplants. There are some combined organ transplants. We did do some children, not much. It's a rare indication, and so the thing that is really striking to see is in the past decades there has been a steadily increase of the donor age. And we last year also transplanted a 94-year-old donor, and the patient did actually well post-transplant. Same trend is seen for the age of the recipients, steadily increasing, now touching up to 60 years as a median age in our cohort. Also, there has been a notable change in the type of transplant procedures. So nowadays, bilateral transplantation has become the standard approach in almost every patient, and this is also seen in international registries, where you can see an increase in the number of double lung transplant procedures being performed. And this is due to the decreased surgical risks of lung transplant procedure, and also the fact that these patients with a double lung transplantation have a better long-term outcome compared to those with a single lung transplantation. Who are we transplanting? Well, there are some general indications. We are transplanting patients with chronic end-stage lung disease for whom there is no treatment and who are very likely to die within the next 2 years. But we also have to think on the long term, and so we have to select these patients who have a very high likelihood to survive up to or longer than 5 years after transplantation. So we really need to be very selective in who we will transplant, and there are now international recommendations for lung transplant candidate selection, which I would recommend you to read. So it's all about actually weighing risks, and you can have a patient who has very few minor risk factors, which is an acceptable candidate, and you can have a patient who has an absolute contraindication who you would defer transplantation from. So it's the garbage in, garbage out principle. I mean, if problems are there pre-transplant, they will only get worse post-transplant, so this is to be avoided. Lung transplant indications have changed a bit over the past decades. You can see that overall 2/3 of patients are being transplanted either for emphysema, cystic fibrosis or interstitial lung disease. For children, this is cystic fibrosis or pulmonary hypertension. But nowadays, in the most recent era, you can see that there is a significant increase in the patients transplanted for interstitial lung disease, and worldwide this is now the most important indication for transplantation in most centers. This is just an overview of the indications in our center. Of the 1,500 patients transplanted, you can see that the majority actually was transplanted for obstructive disorders, emphysema the most common, but 1 out of 4 has been transplanted for interstitial lung disease. For children, you can see that worldwide the most important indication is cystic fibrosis, also in our center. But again, this will change in the near future and is already changing because of the new CFTR modulator drugs. There are now almost no, or let's say no, we also have no patients with cystic fibrosis anymore referred or on our waiting list. And this is true for many other centers in the world. So I think this is really changing the referrals we get for pediatric transplantation. Also important that the patient knows what he should expect or should hope for. We, as doctors, try to save the patient's life or make him live longer. The patient comes sometimes with other expectations, but this is not the primary goal of why we do transplantation. Because this is an illustrative slide. We always aim to make the patient better with the transplant procedure, but you have to also take into account that sometimes the patient may be worse after transplant procedure, which is of course undesirable, but the patient needs to be aware of this fact that this may be unfortunately an opportunity. And if you look at the functional status of the patient surviving a transplant procedure, you can actually see that about 30% functions at the suboptimal level. For the adults, and for the children this is about 20%. And this is mainly due to the fact that many patients will be re-hospitalized after transplantation. This is one of the reasons why you need a good medical team to take care of these patients. About 30 to 50% of adults will be re-hospitalized due to infections or rejection, and in children this is about half of the transplanted children. So really, life after transplantation for many patients is one of continued lifelong care and close medical follow-up. And so you should have a medical team which enables this, and it's really important to have regular checkups in these patients to detect comorbidities or to early intervene if there are suspicion of infection or rejection. This requires a multidisciplinary team, a holistic approach, and a lifelong follow-up of these patients. Basically what we nowadays do after transplantation is taking care of or preventing comorbidities, and you can see some of the most frequent comorbidities here on this slide. And so we're not just lung doctors, we're also endocrinologists, cancer oncologists, cardiovascular doctors, and this is something we need to take into account. This is mainly due to the use of the calcineurin inhibitors, as you know, which have many undesired side effects, unfortunately. And one of those is, for instance, the development of cancer, and you can see that there's a pretty high prevalence of post-transplant cancer, which again highlights the importance of thorough pre- and post-transplant screening and follow-up in these patients. Here's just an illustrative picture of the leading causes of death after transplantation, and you can see even after so many years that infections and cancer, amongst others, are really important to prevent action. So what can we expect? What can we tell our patients on the long term? This is evidence from ISHLT registry again. Best long-term survival is in the youngest patients, which are mostly CF patients. The worst long-term survival is in the elderly patients. Survival of the first year is really key. If your patient survives the first year, he has a very good prospect of living several years. And you can see this ranges up to between 5 and 9 years in this registry. If we look at our own data, we can see that we have a median survival of more than 11 years, which is very nice to be able to say to our patients who are referred for transplantation, we think we can make you live another at least 10 years longer. We have a 90% 1 year survival, and we should actually aim for higher, aim for a 100% survival at 1 year, which should be the future. These are pediatric survival rates, and you can see that also for children we have very good outcomes up to median survival of 13 years. So if you add everything up, you have X number of patients who live X number of years post-transplant. You actually come to an impressive number of more than 10,000 added life years, which were we achieved with the transplantation. And you can also appreciate that 1 out of 4 of our patients in our center lives more than 10 years after transplantation. And our oldest living patient is 82 years. He's now more than 20 years post single lung transplantation. So many medical advances in the past decades have led to better outcomes. I'm not going to go over these in detail, but you can read them. Improved immunosuppressive therapy for sure is a really important advancement that led to better outcomes, but also advancements in diagnostics, infection control, and clot management have led to reasonably good outcomes nowadays. There are still some remaining important problems, and these will be there for sure for another several years. We have still patients dying on the wait list, or patients dying post-transplant because of graft failure, and you can see the reasons listed on the slide for this. And I think many of the things that were discussed at this Congress, AI, big data analysis, bioengineering will be really relevant also for the field of lung transplantation the next decade to further improve the outcomes of our patients. Particularly for chronic lung allograft dysfunction, which is still a very frequent condition. You can see that about half of our patients will develop this potentially lethal condition 5 years after transplantation. This will be important. Maybe we can use AI for the outcome analysis of various parameters to predict which patients will develop clot and maybe intervene earlier in these patients. Just to give you an idea of our own clot prevalence, which is a bit lower compared to the international, and there were more slides, international registry data. So chronic rejection is also one of the most important reasons why we need to retransplant sometimes patients, although this only occurs in a low proportion of our patients. So we really should go for one organ for the rest of their life with better outcome analysis. So to push the boundaries after lung transplantation, you for sure need a skilled cardiothoracic surgical team. You also need, except from a dedicated patient, you also need a dedicated family and multidisciplinary care teams, which are experienced in taking care of many medical problems after transplantation. And also probably you need a research group, like we have ours, who looks into the factors associated with outcomes, and we do actively do research on all these topics to try to improve our patients' outcomes. This is done by several clinical trials, and here are just 2 examples of these, and also by translational research, in which we use mouse models, ex vivo models, to better understand the mechanisms of disease, to detect novel biomarkers, and to identify personalized treatments for our patients. And this will for sure help us to further push the boundaries for the benefit of our patients. I just want to point out on the right lower end of the slide, you see the lady with the dog. This is our longest living lung transplant patient. And then just above her, you can see one of our patients who has delivered her daughter 2 years ago. So, bringing me to my conclusion, I think lung transplantation is now an accepted treatment option because of many medical advancements, not only surgical advancements, also medical advancements. Post-transplant outcome is improving, but still limited due to clot, and I think ongoing research is absolutely needed to further optimize our future post-transplant outcomes. And with this, I would like to thank our team and also you for your attention.